Hello, my name is Dr. Mia Levy, and I'm the director of the Rush University Cancer Center at the Rush University System for Health in Chicago, Illinois. And I'm joined today by my colleague, Dr. Michael Lin, in infectious disease. And we are here to talk to you today about our experiences with COVID-19 in the cancer population and the epidemiology that we're seeing amongst patients with cancer and their risk for coronavirus. Dr. Lin, thank you for joining us today.
It's my pleasure.
Well, I'd like to start first just by asking, what do we know today about the risk of SARS-CoV-2 infection for patients with hematologic and solid tumor malignancies? And are there any differences between the two?
Well, COVID-19 has been such a burden on our patients, and I think disproportionately so among cancer patients. We've looked at observational data from our center, but other centers who have published, and it seems clear that patients with comorbidities, and in particular patients with hematologic malignancies and patients with lung cancer, seem to have worse outcomes with COVID-19.
Yes, I was reading recently, especially those who've had bone marrow transplants or other transplants of solid organs have also been at higher risk of having poor outcomes with COVID-19.
So it's been a challenge. I know, Dr. Levy, it's been great to see that the Cancer Center has been really thriving and open during even the heights of the pandemic. We've gone through our first wave, and we've learned a lot in the last few months about COVID-19 and how to safely take care of patients.
We really have, and it's, these last 3 months have really been a process of understanding how to continue to take care of cancer patients during this time and how to do that safely. We've certainly learned a lot about how to deliver safe care, putting in the right safeguards to protect our very vulnerable patient population who essentially need to continue to get their life-saving cancer treatments. Do you, speaking of our cancer patients, Dr. Lin, we work together very closely to establish some guidelines on treatment of our cancer patients should they become COVID-19 positive. Do you have a sense of how long COVID-19 positivity stays, the virus remains active in patients with and without cancer?
I think we have pretty decent data about live virus shedding in non-cancer patients, and the accumulating evidence suggests that live virus shedding stops after about 9 days from onset of symptoms. This has been supported by studies in multiple populations, including nursing homes and hospitalized patients. But we don't have really much data among cancer patients, so I think this is an area of interest for us to be able to study. And I think because there's still some lack of information about cancer patients, we're taking a more conservative approach to managing patients from a testing perspective and from a treatment perspective, I think.
And when a patient does test positive for COVID-19, we at our institution here at Rush have deferred their ongoing cancer treatment, if we can, during that initial 10-day period of recovery from the active infection. And then we've made a decision to continue that delay in treatment for as long as we can to about 4 weeks. This is not uncommon when patients have other type of infectious diseases and they're undergoing cancer therapy to delay their care until they have a full recovery from their infection, such as influenza, for instance. So this is very consistent with the way we typically would practice. Dr. Lin, have you seen any increased risks of adverse outcomes with cancer patients who do get COVID-19 compared to the general population?
Well, I think looking at our data, we think that there's probably an increased risk of ICU admission and potentially death related to COVID-19 infection among cancer patients. Again, this is also consistent with other institutions, but I think that the most important thing for us to do is to make sure that when we're taking care of patients that they know how to protect themselves from the standpoint of infection control, wearing a mask, staying sheltered. Some of those basic things that all of us are doing in the public are are really heightened for patients who have comorbidities or with cancer. So I think there are ways to be able to navigate, I think, risk from the standpoint of COVID and to be safe.
When we went into the shelter in place in Illinois, many of our cancer patients were really adherent to that, and it really did make a huge difference in the outcomes for many of our patients who did not get COVID-19. As we're beginning to reopen again, we're hearing about other states that are starting to rise in their cases that had previously reopened the month prior. Do you have any recommendations for our cancer patients regarding their approach to reopening as far as the ongoing precautions that they should be taking?
Well, at this point, we're probably about 6 months into the pandemic, and although our numbers in our state look much better compared to 3 months ago, there still is some risk in being out. And so, I think we're starting to recognize that most of the risk comes from close household contacts who develop COVID and then potentially will transfer it or transmit it to household members. And so I think aggressive testing, especially if somebody is sick in the household, and then testing contacts of people who are sick, particularly in the cancer population, is really important. And that's the foundation, I think, for public health to be able to control this virus regionally. And for our cancer patients, it's even more important. I think there are other basic things that we've already heard our public health authorities tell us about, which are to avoid crowded indoor spaces, especially those with poor ventilation, and to make sure that you maintain a 6-foot distance and to wear a face mask. I think those are all sound recommendations that do work, and those are the same principles that we use to protect our healthcare workers, our patients when they're in the hospital. I think it's important to emphasize at home, it's really important as well.
And good hand washing, of course.
Yes. Thank you for reminding me. Yeah.
When we're thinking about our cancer patients, we've put in several processes within the medical center to help decrease the risk for anyone coming to the medical center. Can you talk a little bit about some of those best practices that we've implemented here at Rush and what it might look like when you come as a patient?
Yeah, so I think some of the best practices apply not just to the cancer center, but to the entire system. And so we're talking about basics like monitoring for symptoms and asking about symptoms before a patient comes onto our campus. And so that's built into what we call a symptom screening process. At the point of entry into our hospital, we also have temperature scanners to be able to check the temperature of patients and staff to make sure they're not having a fever when they come. And if so, to make sure that they get taken care of appropriately. When someone's inside the hospital, just like on the outside, they're asked to wear a face mask, and we ask that our patients and our staff wear a hospital-issued face mask because they have a more consistent level of protection, both from spreading or transmitting the virus, but also protecting the wearer. And then when it comes to testing for COVID, this is an evolving field, and right now we're very much in favor of testing patients who are being admitted to the hospital who have symptoms for sure. And with regards to the cancer population, patients who are undergoing chemotherapy, receiving testing, any cancer patient actually coming into our cancer ward does get tested. And so that it is a special population from the standpoint of risk, and we are aggressively testing to make sure that COVID is not present.
You and I have had multiple conversations about retesting for patients who have previously been positive. I know there's a lot of different views at the Cancer Center because we're not entirely sure with the duration of viral shedding in immunocompromised patients. We have taken the approach of having 2 negative nasal swabs for COVID 24 hours, at least 24 hours apart before we would discontinue personal protective equipment and isolation in the cancer center. So, we are seeing that some patients are taking upwards of 40 to 60 days to completely clear their test. Now, it's very difficult for us to know if those patients are in fact still shedding active live virus, because this isn't a viral culture that's being done, and certainly these could be dead RNA. But this has been our approach to wanting to make sure that we're not, when we bring those patients back for treatment and they're in an environment with other immunocompromised patients, that we're taking the more aggressive precautions before we remove their PPE and their isolation needs.
Yeah, I think that's wise. CDC gives us in the infection control community 2 ways to be able to take patients off of precautions. And I think for cancer patients, because we know that they do shed virus potentially longer, just using our experience from influenza and others, I think it's a very conservative and reasonable approach. And I'm really looking forward to getting more data, and we're planning to do that here at Rush, to try to do live virus culturing at some point to be able to understand better the duration of shedding.
Yeah, it's a really unanswered question for these vulnerable populations. And we certainly know from other infectious diseases like RSV or CMV that they can shed virus for months, especially those patients who have undergone transplantation in particular. So very difficult to know for sure when we can really say someone is cleared. I did want to ask a little bit more, share also some of the experiences that we're seeing around the country and around the world with respect to cancer patients and their unique potential risks. So, have you seen any differences in Chicago versus other areas of the country or world with respect to cancer patients that you feel has been unique to Rush, or are we seeing pretty much the same outcomes as we would expect other places?
Well, I think our experience in Chicago has been a microcosm of the United States. I think from the standpoint of disparities in COVID infections and disproportionate infections in Black and brown populations, I think that may also impact our cancer patients as well from that standpoint. Just understanding that some of our populations are challenged from a socioeconomic background, have more difficult times being able to shelter in place. And I think that's something that we're learning as a large city that's very metropolitan and very multicultural. And I think those lessons are important to be able to share with those around the world, that there are really intrinsic disparities that permeate through healthcare. And I think cancer treatment is not shielded from that.
We certainly have seen an increased incidence in the city of Chicago of COVID-19 in the Black and brown communities. Interestingly, though, a large study was conducted with data sharing across East Coast and Midwest medical centers, and it showed that there was no difference in fatality outcomes between white and Black and brown populations for patients who had cancer. So we may be seeing a higher incidence, but at least from that data, the severe complications were not any greater in those cancer populations than not showing that at least racial disparity. But we are seeing that there does appear to be worse outcomes for lung cancer patients who acquire COVID-19. They often have more severe and often more fatal forms of the illness. And this has been seen both in Italy and in the United States. And in particular, we're also seeing patients with leukemias, lymphomas, and multiple myelomas also having prolonged hospitalizations when they have COVID-19. And so their risk is for adverse outcomes is also very significant, even if their transplant was many years ago.
There's so much to be learned. I do wonder about the lung cancer patients. What do you think is driving some of the high mortality rate in that population?
I don't think we have any understanding of the actual underlying biology. It could be related to prior lung injury that made them susceptible to lung cancer in the first place. but they have not seen any particular therapeutic agents that have been associated with worse outcomes. So no differentiation between, let's say, immunotherapy or chemotherapy, or even having had a recent surgery as a predictor for poor outcome with COVID-19 in cancer patients. So still a lot to learn with respect to what might be the factors contributing to worse outcomes in each of these populations. But certainly the fact that lung cancer patients also tend to be older certainly could be contributing to that worse outcome. And what we have seen with respect to age is that many cancer patients are older to begin with, but those cancer patients who are under the age of 50 do have a 5-fold higher mortality rate than their respective age group without cancer. So that's a pretty significant concerning outcome for cancer patients who are younger.
Dr. Levy, I'm curious, since COVID-19 infection really creates such an inflammatory storm in some patients and that leads to bad outcomes, have you seen anything in the literature with respect to cancer patients and their immune suppressives as being potentially protective rather than deleterious for their outcomes?
Yes, we certainly use a lot of dexamethasone as well, which is also just as part of our normal treatment, prevention of nausea and vomiting, for instance. So that's a common medication that's now being used to treat COVID-19, and it's common medication that we use in the supportive management of patients with cancer. So again, we have yet to see a correlation with any protection for cancer patients with a particular type of therapy. There has been hypotheses that perhaps immunotherapy might be protective. And certainly, as we understand that the systemic inflammatory response is one of the major drivers of poor outcomes in COVID-19, there are actually many anti-cancer therapies that are currently being evaluated for their potential use in the treatment of COVID-19 under clinical trials. So I'm sure we'll be learning more as the time goes on.
Yes.